welcome to tonight's webinar, which is I'm joined by Joan Scott, who is a GP and who has a special interest in menopause. Unfortunately, Elaine Miller, our women's health physiotherapist, has had to call off tonight. So really sorry to say that she won't be here with us. But we're still going to press on, and Joan is going to, or Dr. Scott is going to impart some important information about the menopause and the treatments that are available. I just want to introduce myself. I'm Janet Mack and I'm the co-director of the physiotherapy clinics in Edinburgh and Peebles Physiotherapy. And we specialise in physiotherapy for women's health and men's health and musculoskeletal and sports injuries. We are delighted to have so many of you join us tonight, and I'm really delighted to have Joan Scott here. Just to say as well, Joan is also a comedian, and we will be putting a little flyer out at the end of the webinar for you with our up and coming show. So for the next sort of 20-25 minutes, Dr. Scott is going to share her wisdom. And if you've got any questions, if you could put them in the chat function at the bottom, in the chat function, then what I'll do is during the webinar, I'll go through and round up all the questions and we will ask Joan or Dr. Scott to
That's fine.
answer these. The session is being recorded, so if you have to dive off or if you are unable to make it, it will be up on our website and our Women's Health website. And just for privacy, cameras and mics have been turned off for everybody that's joining the webinar. So without further ado, I'm going to hand over to Joan, who's going to tell us about menopause, the medical aspects of menopause and the current treatment options available.
Hi, my name is Dr. Joan Scott, and I am a GP in the Scottish Borders. I just want to check that everybody is hearing me okay. If there's any problems with any sound or any issues, hopefully you can let Janet know that either by commenting. So otherwise, I'll just be talking to myself, and I've no idea whether anyone's listening or not. Hang on, we've got a hand up there. I noticed, so maybe just check that all our sounds all okay and you're hearing me. So I'll just carry on unless there's any other problems. So today we're talking about menopause. So I am as I say, a GP, but I'm also a middle-aged woman. I am 52, and so I'm very much in the throes of the menopausal situation myself. I'm the mother of two children, and I spend a lot of my daytime talking to women about the menopause. So, I mean, the first thing that I think is probably a good place to start would be exactly what the menopause, what is that word? What does it mean? And I always like to take it back to the meaning of the word, and it's from the Greek, meno meaning monthly, and pause meaning to cease or to stop. It's sometimes also known as the climacteric, but that makes it sound a bit like the scene in When Harry Met Sally. So we tend to just call it the menopause. And what is the menopause exactly? I guess many of you will know what that is, but the definition is that it's a time that marks the end of a woman's reproductive life. So basically, there's a decline in their estrogen and they're no longer able to produce any mature eggs. So essentially, you run out of eggs and you stop having periods and become awesome and get to wear white trousers again and go on cruises. And not have to worry about getting pregnant. So that's all good. So technically, the menopause is the very last period of a woman's life, but you only generally know that in retrospect. So always good idea, when you're approaching your late 40s and 50s, to keep a note of when your periods are. And the last period we take, you only know that in retrospect once you've gone a whole year without a period. So if you've gone a whole year without a period, then you're essentially into the post-menopause. The last period was the menopause. We also hear about the word perimenopause. So peri just meaning around the time of menopause. And the perimenopause is the time essentially that leading up to that final period in a woman's life. So generally speaking, we see a decline in ovarian function from about the age of 35. But most women are starting to get into a perimenopausal period around about 45, with the average age of the menopause between 50 and 52. Um, so that so why do we go through the menopause? We don't know. Humans are one of the very few mammals on Earth that go through the menopause. I don't know exactly how many animals do. I know that some whales do, and possibly some other apes do, but it's a very, very small number of mammals that go through the menopause. And there is, it's called the grand math hypothesis. That's what evolutionary biologists call it. And the idea being that humans, because it takes, sort of 20 years or so to raise a child, or longer if you've still got a 30-year-old at home living on your sofa, then the idea being that women need to stop reproduction themselves so that they can support their grandchildren. And that's the theory behind why we go through the menopause, but we still live another third of our lives postmenopausally. Okay. I like to call men being able to father their children into their 80s the Mick Jagger hypothesis, but that's just my own little hypothesis. So in terms of the symptoms of menopause, again, a lot of you will know what those symptoms are. They can be many and varied. I imagine if you're listening to this, you've probably already, perhaps had some symptoms, and that's maybe what's brought you here today. If you listen to people talking about menopause, menopausal symptoms can be just about anything, but there are some ones which we can sort of definitely blame on the menopause. So doctors call them vasomotor symptoms, but that's basically hot flushes, night sweats. Those are the classical menopausal symptoms. But there's a whole host of other things. If Elaine had been here, we would have talked a bit more about vaginal dryness. So, essentially, the vagina is a very estrogen dependent organ, and I like to use the word velvety about it. So, because when you have estrogen, the vagina has lots of nice curves and a nice velvety and internally. After the menopause, it becomes more, the medical word is atrophic, which is not a very, very nice word, but basically just means that it's not got the nice ridging, and women can experience dryness essentially. And that can cause pain on intercourse, and it can even cause a little bit of bleeding as well. It also can cause urogenitary problems as well. So what I mean by that is bladder problems. So bladder infections become more common after the menopause. Women often get an increased number of urinary tract infections, and again, that is a treatable thing. So we can come back to talk about that. Other symptoms of the menopause that women will be familiar with would be certainly things like difficulty sleeping. So a lot of women report not being able to sleep as well. I mean, I think certainly if you've had a family, often women having kids kind of ruins your sleep often, and it doesn't always get better after that. But certainly the menopause can make that worse. And that's not just because you're having hot sweats and flushes and night sweats, but just difficulty getting over to sleep again, perhaps ruminating on things. And I always talk, when I'm talking to menopausal women, I'm always very much aware that that time of your life is, you've got things coming at you from different angles. You've often still got dependent children in your household that you're looking after, teenagers perhaps that are needing you, even though they're nearly grown up. You've also got, on the other hand, you've got elderly parents who also need you. You're often at the pinnacle of your job as well. So there's a whole heap of things which come together, and then you chuck in the menopause as well, and that really can affect your sleep. Women experience sort of low mood and anxiety as well. So again, often that can be the first symptom that you go to your GP about. I'm struggling with depression, or I'm struggling with anxiety, and that is, so sometimes a doctor will be trying to send you down the route of taking medication for depression or anxiety. But when actually the problem is menopause. Libido can be affected. That's a very, very big topic, libido, one which we don't have time to discuss today. But again, women do experience a drop-off in their libido. But actually, some women postmenopausally experience a pickup in their libido. So, it is a bit of swings and roundabouts there. Women often talk about their brain fog, maybe a term that you've heard of, your memory not being so good, a bit like baby brain when if women have been pregnant, they would experience that. So it can affect your concentration, and memory. A lot of women sort of feel like they really just have to write everything down, or they just really start to worry even about early dementia, when actually it's to do with the lack of estrogen, because estrogen is a hormone that is not just about all your women's bits. It's not just about pregnancy. It's not just about breasts. It's not just about vaginas. It's also your brain has estrogen receptors. So when you experience a drop in your estrogen, your brain is also not getting the estrogen that it needs to be the best version of yourself. Another symptom that a lot of women complain of is increasing joint pains. And again, that again comes at a bad time. But starting to get aches and pains is often, goes all hand in hand with the menopause. And again, that can be a number of things. It can be different other problems. Often women do start to get wear and tear in their joints, in their late 40s, early 50s. But equally, it could be menopause. Some women experience an increase in headaches. You can have fatigue. If you were to look at a list of, I've just really scraped the surface there, but those, I suppose, would be the sort of top ones that you would get. And I think when you see a medical professional with symptoms which might be menopause, your GP might want to just check out some other things. In fact, I would probably welcome that. I think sometimes GPs are criticised for not taking the menopause, seriously, and that's a fair comment. But if you come in with a multitude of symptoms, the GP's job is to make sure that we rule out other things as well. So we absolutely want to rule out other causes of headaches, or other causes of fatigue, or other causes of poor concentration or low mood. So your GP might embark upon some tests, to try and exclude those sort of things. Again, I guess everything can be blamed on the menopause, but at the same time, you don't want to be missing something else. Is what I'm saying. Your GP has to do sort of due diligence to make sure that they're going down the right path. But once you have essentially excluded any other serious causes, then you're left with the menopause, and we can talk about how we treat that. So I mean, how do we know if you are perimenopausal or menopausal? Essentially, the first question that I would ask women is what's happening with their periods. If you are still having regular periods, and they're pretty much spot on, and you're not experiencing a lot of these symptoms that we've just described, then you're probably not quite at the menopause yet. However, if you are over 45, you're experiencing some of those symptoms, and your periods are starting to become a bit more erratic. And by erratic, I mean either a bit closer together or a bit further apart, then you are probably entering the perimenopause at that point. Now, people often ask, do I need a blood test to test for the menopause? Now, I've already mentioned blood tests in the context of excluding other health problems. Your doctor might want to take, for example, a blood test to check for anemia. If you've come in saying that you've got heavy periods or you've got a lot of fatigue, they might want to check these other things. They might want to check for your thyroid, for example, as well. But women often ask about, do I need a blood test to determine whether I'm in the perimenopause or menopausal? Now, the short answer to that is probably not. Okay, if you are over 45, then you will be starting in the perimenopause, and blood tests will not be particularly helpful in determining that. Now, the reason for that is that your levels will fluctuate on a potentially sort of hour by hour basis. So, if you had your blood test done and then repeated again in an hour, you could potentially have completely different levels. So it is not particularly helpful in telling us where we're at, essentially. Where doctors will use blood tests would be perhaps if we think that a woman is having a premature menopause. So, essentially under the age of 45, especially for women who are maybe still thinking about pregnancy. More and more women between 40 and 45 are still perhaps trying for a baby. And if we think they are going through a premature menopause, then we will check blood tests to see more to do with their fertility than really menopause, if that makes sense. So essentially, for those women who are starting to have some symptoms, whose periods are becoming a little bit erratic, then you can essentially say that you are, and you're over 45, you're essentially in that menopause, perimenopause. So, I think that brings us on to how we treat it, and again, lifestyle is often the first thing. In reality, most of the women that come to see me, by the time they've got an appointment with the GP, let's face it, not the easiest thing to do, have already explored, they've read up some stuff about the menopause, they know about diet and lifestyle, and it's the same stuff that doctors are going about all the time. It's avoid heavily processed foods. Try to make sure that you get your exercise. You try to get 20 minutes 3 times a week of moderately intense exercise, or at least just try and get your step count in if you can. We talk about sleep hygiene, switching your phones off, trying to wind down for bedtime, trying to relax. I talk about sort of feeding your soul as well, just making sure that you're getting time for yourself, away from your family and work commitments, and you've got a chance to recharge your battery. So I think, most of us know what our phone battery is at, don't we? We know what the percentage of our phone battery is. And I often use that analogy to talk about how you recharge your battery. So if your battery is low, when you think, oh, how am I feeling just now? My battery about 25%. I need to do something to recharge it. Because we are having our battery drained all the time, as I said, by our families, by our job, by our other commitments that we've got. So trying to recharge that battery, and that might be meeting friends, that might be exercise, that might be just whatever you enjoy, whatever fills your cup, fills your battery. So these things are all things you can do. Mindfulness is good. Very few people have access to things like cognitive behavioural therapy, but these things can be helpful. But the primary management, certainly as far as I'm concerned, and as far as most medical doctors are concerned, if you have got these vasomotor symptoms, in other words, the flushing, hot flushes, the night sweats, the lack of sleep, then absolutely HRT, hormone replacement therapy, is very much where I would be what I'd be offering a woman that came to see me with those sort of symptoms. There is a bit of a debate about whether HRT works for all of the spectrum of symptoms that we've talked about, which is why the lifestyle and other things are also helpful. But in practice, women tend to find that HRT does help quite considerable number of their symptoms. So again, you know, who can have HRT, who can't have HRT? In terms, most people is the answer, can have HRT. There are a few sort of absolute contraindications. If you're pregnant, you can't have HRT. If you've got undiagnosed vaginal bleeding, so in other words, if you were having bleeding that was spotting between your periods, or you were having bleeding after intercourse, those would be abnormal types of bleeding. And we wouldn't want to give somebody HRT until we'd worked out what was happening with that. If you've had a recent blood clot, a heart attack, or a stroke, if you had active breast cancer or womb cancer, or you had active liver disease, these would be things which would be, we wouldn't be keen to be giving you HRT for. However, having a family history of breast cancer doesn't preclude you from having HRT, but that is a conversation that you might want to have with your prescriber. So in essential, and even these days, there will be some women who have had breast cancer that will still be able to have some form of HRT. So, for example, localized HRT. Now, what I mean, and I'm going to come on to talk about the different types of HRT, but what doctors generally talk about is systemic, which means patches, tablets, gels, sprays, and localized HRT. Now, when I'm talking about localized HRT, I'm talking about creams or pessaries that are put up into the vagina that can relieve vaginal dryness and can help with pain on intercourse and help with these UTIs that I mentioned, urinary tract infections that I mentioned earlier. Now, even women who've had breast cancer can have these treatments. Now, in reality, we often, ask women to check with their oncologist or their breast surgeon, just because of the different types of breast cancer. But nearly always, women can have a local form of HRT. And they can have that because we know that the amount that is absorbed into your body is very small. And they've done the research on this. They've checked women's blood tests, and we know that the estrogen is just going to the tissues that need it. And what kind of HRT, can you get? Now, your GP, most GPs in the NHS, if you're in the NHS, if you're in Scotland or further afield, will use a formulary. Now, the formulary is designed by the local health boards, and they will generally stick to the drugs that are on that formulary, which they've been asked to prescribe. I mean, that's often for cost reasons, but it's not just cost reasons. It's the drugs that have been shown to be the most effective. There has been issues with supply for HRT, so that can sometimes influence what your doctor's able to get for you. Those supply problems are hopefully a thing of the past, but occasionally we still see problems with women not being able to get the HRT that they have been prescribed. Again, I think it would be helpful to talk about the different preparations of HRT, and I, as a GP myself, I generally prescribe what's called transdermal HRT, so transdermal, through the skin. Okay, that's what that means. The reason that I prefer that is because it's safer. Okay, if you take oral HRT through tablet form, the way that it's metabolized through your body is via the liver, and that puts your risk of things like deep vein thrombosis, which is a blood clot in your leg, which can go into your lungs and cause, quite serious damage. That goes up. So the safest form is to have it through the skin. Okay, have your estrogen through the skin. So that's usually through a patch, but you can get gels and sprays, which some women prefer because some women react to the patches. I've brought a patch just to show you. So this is one. I don't know if you can see that there on the camera. It's back to front, but Everell 50, which is what the patch looks like. And if I just open the packet, you can see what they're different ones. They're different sizes. Estradot, I think, is a bit smaller, but you just open that and stick it in the lower half of your body. So usually on your lower abdomen or your thighs, below the breasts. So that's what that is. And there are different types of patches or combinations, depending on where you are. If you are in sort of early perimenopause and you're still having periods, then you would need a cyclical HRT. So that would still give you periods. Once you are a bit more advanced, or if you've completely stopped your periods, you can have a no-bleed HRT. The problem is if you go for a no-bleed HRT too early, you may have erratic bleeding, which then, it can be a little bit problematic because you don't know whether or not the bleeding is due to the HRT or it's due to some other abnormal reasons. So the timing of that is important. Some women do take oral HRT, and there are other ways of taking the combination of estrogen and progestogen. So, I'll just talk a bit about why we need estrogen and progestogen. So estrogen is the thing that we really need because that's the thing that we're lacking. But if we've still got our womb intact, our uterus is intact, if we've not had a hysterectomy, then we can't have estrogen on its own without the progestogen. Okay. If you give a woman estrogen on its own and she still has a uterus, what happens is the lining of her womb thickens, and that can put her at risk of endometrial cancer. So you need the balance of the two hormones. However, if you've had a hysterectomy for some other reason, then you don't need the progestogen. You can just have the estrogen on its own. Some women can use different ways of getting. So assuming you've got your uterus that's still intact, you've not had a hysterectomy, you've still got your womb, then there are different ways of getting your estrogen and your progestogen. You can get them both through a patch or a tablet, or you can get the estrogen through a patch or a gel, and the progestogen you can get through a tablet, or, which is my preferred option, through what's called the Mirena intrauterine device. So a Mirena coil, which is the intrauterine device that is put up into the womb, and it has the progestogen within that. And that in itself will keep the endometrial lining thin and allow women just to have the estrogen, the estrogen only patch like this. So that is one of the safest ways of doing it, and it almost certainly stops your bleeding completely and takes away this problem that some women have with HRT, which is of erratic bleeding, which can be one of the side effects of HRT, which in and of itself is not a problem, but it's just that you sometimes then have to go for a scan just to make sure that everything's okay. Side effects of HRT, I find very rarely do my patients have side effects, but I would say two of the more common ones would be a bit of breast tenderness, and also sometimes women get a bit of bloating, abdominal bloating. Now, again, sometimes by adjusting the doses, we can mitigate that as well. So that can be quite, but it's possible to do that. In terms of the benefits, now I like to divide this into two, in terms of, if women are asking me what are the benefits of HRT. Well, first of all, there's the short-term benefits. So we've already talked about the symptoms that women are having. We're talking about the flushes, the lack of sleep, the concentration, aches and pains. Giving a woman HRT can help a lot of those symptoms. So that would be the number one indicator for HRT. But there's a second indication, and that's the more the long-term benefits. And we absolutely know that HRT helps women's bone density. And personally, I see a lot of very frail elderly people of my parents' generation, women who have lost height, who've fallen, who've fractured wrists, who've fractured hips, who've had terrible back pain because they've had vertebral fractures. And these have been through osteoporosis. And we know that if you are using HRT and you extend the amount of time that you have estrogen in your body for, you will reduce the chance of you becoming frail and breaking bones. And as I say, that's one of the things that I fear most about getting old, is becoming a crumbly old lady that's not able to look after herself. So those are the benefits. We also know that premenopausal women have better cardiovascular health than men. And if you start HRT in the sweet spot, so in other words, if you start HRT within the sort of immediate years post-men or around the menopause, so certainly within the first 10 years, so under 60 essentially, then your cardiovascular markers are better, your cholesterol is better, etc., etc. The jury is out around dementia. There's an awful lot more work is needed. I personally think that it makes a lot of sense that HRT does help to protect the brain, but that has been quite hard to prove up until this point. But you've got to remember, dementia is more than one different type of illness, and if you are improving your cardiovascular system, then you're hopefully going to prevent at least some types of what we would call multi-infarct dementia, which is different from Alzheimer's. But again, I don't have time to go into that just now. The risks of HRT, most women will know about some increased risk of breast cancer. That has been the thing that has historically put women off having HRT, the worry about breast cancer. And that goes back to a study that has been essentially mainly discredited now, called the Million Women Study, which took women and gave them HRT and then followed them up. And they discovered that there was a rise in breast cancer. However, that study involved women starting HRT who were already well past the menopause. So in other words, women in their 60s and their 70s were then being reintroduced estrogen, which is a different scenario from somebody in their late 40s, early 50s, starting HRT and continuing. Unfortunately, breast cancer affects 1 in 8 women in their lifetime. So, the relative risk is there. But in terms of the absolute risk of additional number of cases, if you're taking HRT, it's actually really pretty small. If you're interested in the actual statistics, I would encourage you to have a look at, there's a NICE guidelines, Janet, it's NG23, which we might be able to give a link to, that has very nicely outlined the stats on how many additional cases, and it shows it in a really nice way. It shows it the number of people per 1,000 with that condition who haven't had HRT, and then the number of people who have HRT, the additional number of cases, and they do that for a number of different illnesses. And you'll see on that in some cases the risk is increased, and the risk is decreased. So, but the risk is pretty small in all of them. But if you are somebody that is really unsure about whether HRT is right for you and you're really worried about risk, then I would encourage you to have a look at that NICE guideline NG23. So how are we doing for time, Janet? I'm wittering on.
Probably got about 5-10 minutes left for questions.
Okay.
I've just popped the NICE guidelines NG23 link in the chat, so hopefully you can see, everybody can see that.
So do we have any questions?
Oh, sorry, let me just have a wee look here. So yes, I've got the first question I've got here is, will testosterone help my symptoms?
Okay, so yes, testosterone is one of the three female hormones. We don't, it doesn't really get an awful lot of attention, but women do have testosterone, and our testosterone levels will drop. There has been a lot of interest in testosterone, and currently there is no female preparation on the market. So we end up using essentially what's called unlicensed male testosterone, which is designed for men, and that is we adapt that for use in women. Currently, on the NHS, we are only supposed to use testosterone for women with low libido. I personally am happy to try it for women with other sort of more tricky symptoms, perhaps a bit of fatigue, perhaps where the HRT alone hasn't helped. But other GPs will not always go off piste, if you like, and prescribe out with those circumstances. So, but what I would say is that it is not a panacea. I know that it has been majorly touted as being something that women should definitely try to get. I've used it a lot in my clinical practice. I've not necessarily found it to be that panacea. A lot of women will take it for a while and then not necessarily feel it's made a huge difference, which kind of correlates with the data that we have from research. But if it is something you're interested in, I would encourage you to speak to your prescriber. And if you can't get that on the NHS, you can certainly look to see whether you can access that privately. But as I say, I think it's not necessarily panacea. And certainly for libido, I would certainly say that women's libido is quite a complex beast. And certainly increasing the testosterone is not all of the answer.
Great, thanks for that, Joan. I've got another question that's come in. Should every menopausal woman take HRT? What's your view on that?
So I think I'm, as you can probably tell, very pro HRT. I'm not going to say anything other than that. I am very pro HRT, and I think all women should have access to that discussion and see whether it's right for them. You will have some women that sort of sail through the menopause who don't have any vasomotor symptoms of hot flushes, etc., and they might feel that they don't want to be bothered with HRT, which is absolutely their choice. But they do potentially have that risk of osteoporosis and these other health problems. So, as I say, it comes back to that argument, you're using it for short-term relief of symptoms, but also perhaps the long-term benefits. But it is very much an individual choice. And, still in this day and age, you will get GPs that have different views. I mean, I think there's been a lot made of the fact that GPs are not all well trained on the menopause. And I would certainly encourage you, if you have got a middle-aged female GP in your practice that you can speak to, they will almost certainly be the person that knows the most about it. Not to be disparaging about my male colleagues or my younger colleagues, but older female GPs will generally know more about these things. So if you find that your GP doesn't seem to know much about it, or seems a bit reluctant, you try and make an appointment with somebody else.
Brilliant, thanks, Joan. I've got another question here. A lady's had a full hysterectomy and breast cancer.
Mm.
Is she still able to use a patch or a cream to get estrogen and progesterone? So, a participant that has had a full hysterectomy and breast cancer.
So I think the first thing I would say is that coming back to the local HRT would be something that I would have thought would be possible. So Fagifem is the pessary. There's an East ring as well. You can have a ring put in, or you can use there's the estrogen cream. For most breast cancers, that is absolutely fine. So even with a hysterectomy, you've still obviously got your vagina, you've still got your bladder. Having a local HRT is still possible. As far as a systemic HRT, in other words, the patches or so on, you would need to discuss that with your oncologist and or your breast surgeon. There are types of breast cancer that are I'm not an expert, but there's more hormone sensitive ones, and there are other ones that are not so much. And there is a big debate around this whole thing, but currently I would recommend going with your oncologist or your breast surgeon's advice on that. But almost certainly you would be able to have local estrogen in the form of a pessary or cream.
Okay, brilliant. Just to say, if you've got any questions, if you pop them in the Q&A box at the bottom of the screen, then we can deal with them then. So I've got another one, Joan. What are bioidentical hormones, and are they any better to other hormones?
Okay, so again, bioidentical is something that is bandied about. It's mentioned quite a lot, and bioidentical just really means the same. Bioidentical, so it just means are they the same as your body's natural hormones? And essentially, the what we prescribe, what doctors prescribe, is bioidentical essentially. But when other clinics and things talk about bioidentical, they're often talking about making up different formulations of what are essentially often untested combinations. So I would certainly advise to sort of steer away from that, stick to things which are properly tested, and that we know are where they've come from. But when people ask me, is it a bioidentical? Well, I just say, well, it is in the respect that it is replacing the estrogen and the progesterone that is in your body, then yes. But the term bioidentical has come to mean something else. It's about people putting together a combination of hormones to apparently meet your exact specification. And actually, there is no evidence for that, and I certainly wouldn't pay any extra money or anything like that. There's absolutely no evidence that that is beneficial, and of course, and it might be actually harmful. We just don't know where these things have come from.
Okay, thanks, Joan. That brings us to the end. We've run out of time for any more questions. There's a few more there, but I think we're sitting at 45 minutes. Um, I would just like to say thanks very much, Joan, for imparting your menopause wisdom and your treatments available. And I'm just sorry to everybody that we weren't able to have Elaine Miller, the physiotherapist that works with the physiotherapy clinics and specialises in women's health, because I think Joan and Elaine together very much we would use the medications, and often in conjunction with physiotherapy, the two modalities of treatment together can be really effective towards menopausal
Yeah,
symptoms, including the
yeah.
sort of leaking and pelvic floor. Um,
So I've not talked about that side of it, but I know Elaine has talked about that before about the postmenopausal problems that women have with their bladders. But certainly the local HRT or any form of HRT will also help the bladder side of things and the continence side of things.
yeah. So, yeah, thank you. So just before we finish, Joan or Dr. Scott not only is a GP that has an interest in menopause, she's actually also a comedian, and Joan has
I,
got a show that's coming up in
will,
Glasgow.
will I sell it,
Yeah,
Janet?
you can sell it. You sell it
So
better than I will.
if anyone's interested, I also perform comedy under the name. I've got a pseudonym. Try and keep my medical doctory stuff slightly separate from my comedy stuff. So my comedy name is Jeannie Jones. So Jeannie with two N's, Jeannie Jones. And I have a show at the Glasgow Comedy Festival called Aphrodisiac. And it is medical in the sense that it talks about sex and sexual problems for people in long term relationships. So it's got quite a lot of medical stuff, a lot of humour. And as I say, if you wanted to, I think Janet's got the flyer for that.
I'll put
If
that
you've
on
got any
our
friends in
website.
Glasgow, then if you want to follow me on Instagram as Jeannie Jones, then that would be lovely. But thank you for letting me do this and inviting me, Janet.
Thank you, Joan. Sorry, I'm not able to share it there for some reason, but we will share the information on our website as well. So if anybody's interested in that, I'm
Thank you,
sure it'll
Janet.
be a great afternoon in Glasgow. So that brings us to the end of tonight's webinar. I hope you've all learned lots. I certainly have. Thanks a lot for coming along, and thanks to Joan for hosting tonight. Thank you. We will be hosting some more webinars on Eventbrite, so just we'll keep in touch. You can look at them on our website and also be advertising them on Egg. Thanks a lot and good night. Bye bye.